So this is definitely by far one of the top most difficult topics to talk about. The spinal cord and associated tracts. So I've already actually made this video like twice so far. Each time there were certain tiny mistakes. I was doing such a good job along the whole path, and then there's something that I would say that was off. So this is the third time I'm making it, and I feel like I know this inside out now. Like I've been teaching neurology forever. In the previous videos, we looked at the location of your cranial nerves, right? We were doing basically neuroanatomy, the location of your cranial nerves, the distribution of your arteries in the brain, right? The circle of Willis, the skull, where things exit on the entire brainstem, right? Which is also very critical. And we talked about all the different things that you can use to memorize, right? We have these mnemonics right here, the 4-4-4 method of knowing where things are in the pons, above the pons, or in the medulla. So with respect to the pons always, which is right here, this thing, 4 above it, 4 at the pons, and 4 below it in the medulla. Various images, right? We looked at a bunch of stuff. Now we're going to see the last thing, which is your spinal cord associated tracts, right? So there's tracts that help you either sense things or move, right? So ascending fibers are fibers that come from your body and go to the brain, and they help you sense things, all right? So they're just sensory. Whereas descending fibers, they come from the brain and they go to different parts of your body, and they're for motor activity. All right, so that's the general breakdown. You have to know how different parts of your spinal cord and brainstem, all that, how they look when you take a cross section like this. So when you look at this cross section right here, for example, anytime you see something similar to this butterfly thing happening in the middle, that's your anterior horn, right? Then you have your posterior horn and your white commissure. When you see this kind of stuff, this means that you're in your spinal cord. So this is below the brain, right? You haven't gotten to the brain yet. And in your spinal cord, there's 3 segments. There's this big part in the back, big part on this side, and big part on this side. Now, anytime you're looking at any image like this one, right? This is supposed to be a patient that's looking at you. So this is the anterior, right? So this is a patient looking at me, which means this side is their left, right? And there was a lot of confusion with this stuff previously as well. So this part is their left. Right, so this entire half over here is their left half. You have your dorsal column, the left one. You have your left lateral corticospinal tract, left spinothalamic tract, anterior spinothalamic tract. Right, this is all for the left, and things decussate, which means they cross over. No, I'm gonna fix that right now. It was wrong in the previous video, so I'm fixing that. I actually emailed you back as well. So in this video, I'll get it correct with the image A and B stuff. So when you're looking at the spinal cord, all the things on the left, right, they decussate at the medulla or before it somewhere, right? Majority of the things decussate at the medulla, which means that by the time these things reach to the brain, they're going to be on the other side. So if you're looking at your spinal cord, right, if you're looking at your spinal cord, then everything is on the left here, and chances are if it's going to decussate, then by the time it gets to the brain, it'll be on the right side of the brain, right? So make sure you get that down too. Now let's take a look at our different tracts, right? So we have our 2 ascending tracts and 1 descending tract. That's basically all first aid talks about. I'm going to mention a couple other tracts, and I'm going to try to make some more connections here and there so that you can really grasp what you need to know to tackle clinical questions rather than just knowing unnecessary information. So let's look at the 2 ascending tracts first, right? So we're looking at the left half right here. The left half here, they're showing you your ascending tracts, which are sensory. Your dorsal column is mainly for proprioception. Just keep that in mind. Anytime proprioception is messed up, that's your dorsal column. And in your dorsal column, there's a more medial section and a lateral section. And you can see how it's broken down: cervical, thoracic, lumbar, and sacral. Very much like this stick figure human right here. So what that's supposed to tell you is that this medial part, also called the fascicular gracilis, that medial part is for your legs. So the proprioception of your legs. Proprioception basically means knowing where your leg is when your eyes are closed. So if your eyes are closed and someone kind of moves your leg, you should be able to say where your leg is pointing. The lateral part of your dorsal column is the fascicular cuneatus. that's for your arms, right? So upper body, arms. And that's going to be the proprioception of knowing where your hand is if your eyes are closed, right? And that's generally all this is going to be responsible for. They also list out pressure, vibration, and fine touch. However, a lot of that kind of gets blurred out by your anterior spinothalamic tract, which also does crude touch and pressure, right? So pressure is overlapping, fine touch and crude touch is overlapping. Vibration and proprioception are unique to your dorsal columns. Now, the other tract, your spinothalamic tract, we've talked about quite a bit already. When we were earlier in neurology, when we were looking at syringomyelia, it was your spinothalamic tract that was getting messed up bilaterally because you had a compression with the syrinx at the anterior white commissure, right? And this syrinx stuff that was happening was actually in your spinal column. It wasn't in the brain, right? The syringomyelia issue was actually in the spinal column, which tells you that your spinothalamic tract most likely actually decussates in the spinal cord, which is true, right? The dorsal columns and your corticospinal tract, these guys have decussation in the medulla. All right, so that means that fibers are going to cross over and then go to the contralateral side of the body. But your spinothalamic tract decussates right in the spinal cord itself, which is why syringomyelia is a thing. And if you mess up the syrinx, if you have something compressing the syrinx, you're going to mess up this one crossing that way and this one crossing this way, hence bilateral loss of pain and temperature. All right, so that's something that, you're connecting the dots between syringomyelia and spinothalamic tract, and you're memorizing and understanding the decussation of the spinothalamic tract actually occurs in the spinal cord itself. The last thing we have is our descending tract, our lateral corticospinal and anterior corticospinal tract. You don't need to worry too much about the difference between one and the other. Generally speaking, it's just your corticospinal tract. Your corticospinal tract is a motor tract, right? So they tell you voluntary motor. So this tract basically comes from your brain, goes down to different parts of your body, and helps you move. Now, just like we saw the legs and arms being a thing for your dorsal column, either medial or lateral, it's also a thing for your corticospinal tract and your spinothalamic tract, as you can see over here, right? So it's the more medial stuff, however, the stuff closer to this butterfly figure, is now your head and your arms, right? So you can see they tell you cervical is all the way over here. The most outer portion is sacral. Same thing for your spinothalamic tract. The most inner portion is cervical. The most outer portion is sacral. Okay, it's in the dorsal columns. That is a little bit of a flip there, but it's not too hard to memorize because in the dorsal column, the gracilis, they have this thing for you to memorize. So gracilis has an L for lower body. Cuneatus has a U for upper body, but when I was studying this, I was taught, gracilis for having graceful legs, right? So you can also think of a ballet dancer or someone that's like spinning on ice. When you spin on ice, you have to close your legs in to really spin quick and put your arms outwards, right? That's like a spinning on ice kind of physics thing. So if you want to spin really, really quick, you have to close your legs inwards, and that's kind of what's happening here. Your legs are more medial, but your arms are outwards. That's what the dorsal column is kind of for. And spinning on ice is a great example because you usually have your eyes closed, and you're working based off of your proprioception of knowing where your arms and legs are, even though your eyes are closed. So that was a really interesting way one of my professors had taught it to me, and it kind of stuck to me. So it was pretty good. Right? So the stick figures here really help you see the distribution and the difference between upper and lower limbs. Now, these two images here are things that you also need to know because this is where the pathology will arise. What we just looked at was your spinal cord, right? So we're looking at your spinal column here, and that's it. From here, information is either going to go up as an ascending column, or information has already come down for your descending tract, right? Either way, information has to have a connection with your brain. That connection to your brain is based off of these guys. So what are these guys? Both of these are actually your medulla, all right? This one here is the actual medulla. You're at the central medulla. This image here is a little bit lower, right? So this lower image here is between the spinal cord and your central medulla. So this is often called your caudal medulla and stuff like that. These are the guys where you're going to have pathology. So you need to know the different parts of this. First things first, in your medulla, you can already kind of see the same guys that we just talked about for your dorsal column, right? This is your gracilis, this is the cuneatus, right? You have your spinal nucleus over here, and that's also going to be significant with the trigeminal nerve. These guys on the side, your spinocerebellar stuff, okay? And then in the middle, the two most important things, you have your medial lemniscus and your pyramid. You need to know all of these segments really, really well, because those are going to be either answer choices on questions or part of the question stem where something in these guys was lesioned. Alright, so when we look at our tracts on the next page, you're going to see these guys being mentioned. You're going to see the medial lemniscus being mentioned. You're going to see the pyramid being mentioned. These are all actually parts of your medulla in the brain. Right? And then, of course, we already talked about these two nuclei. But right next to, you see the third nucleus. So from medial to lateral, you have your gracilis, cuneatus, and then your spinal nucleus. This is also significant. If you ever hear anything about olives or olivary nuclei, it's this guy right here. Usually shown as a squiggly line on your medulla in this exact area. Okay. Other than that, there's a bunch of other things happening, but we're gonna make the connections as we go on. The only reason your caudal medulla is important is because that's where your corticospinal tract. This is your corticospinal tract. This red thing here, lateral corticospinal tract. I would make the image bigger, but it gets a little blurry when I do that. But either way, this is your lateral corticospinal tract right here, and decussation is occurring using the pyramid, as you can see, in your lower medulla, right before you reach your spinal cord. Okay, and you still have your nucleus, gracilis, and cuneatus in the back, right? They're looking a little different now because now you're about to start entering. You can see the butterfly formation is starting to show up now because after your caudal medulla, you're going to be in the spinal cord, right? So the transition is very evident here. So let's actually go into your tracts now. Let's take a look at the tracts on the next page, right? So in your tracts, you have your two ascending tracts, the dorsal column, your spinothalamic tract, and you have your one descending tract, which is your lateral corticospinal tract, right, for motor activity. On this page, in the table format they break down the first order neuron, the second order neuron, and the final synaptic location. Right, so obviously for your ascending tracts, the final synaptic location is actually your VPL, ventral-posterolateral nucleus of the thalamus, which we said the L stood for limbs, right? So sensory cortex in your brain, the somatosensory cortex in your brain is where all the information, when we were looking at the homunculus earlier, right, different parts of your sensory information get there. So VPL was for limbs, VPM was makeup on your face, it was for the face, right? So we're not seeing anything about the face here. But just to do a quick look at it one more time, what we're talking about is this right here, right? So we're looking at our sensory homunculus, okay, VPL. The thalamus is going to send information to your sensory homunculus, where remember that the foot stuff, your legs is medial, right, and your arms are more lateral over here. And this was very relevant because there's blood supply that's significant to it, right? We can see the anterior cerebral artery is going to be related to your legs, and your middle cerebral artery is related to your arms and your face. On top of that, you also need to remember the location, right? So your primary motor stuff is anterior. Even when we talk about our spinal cord, the anterior horn are for motor things. So it's anterior in relation to the central sulcus. Primary motor, right, or your premotor cortex, all of that stuff is in front of the central sulcus, right? This is the front of the head, this is the back of the head. Behind the central sulcus is your primary somatosensory cortex. So that's where everything sensory is going. Everything motor is coming from here. So let's go back to 551. Okay, so now let's take a look at each of these tracts and understand your actual neurons, right? So you have your ascending tract dorsal column for pressure, vibration, fine touch, and proprioception. You have your first things, right, actually coming from your body. Right, you're sensing whatever you're touching or wherever your proprioception is. Sensory nerve endings bypass the pseudo-unipolar cell body in the dorsal root ganglion, enters the spinal cord, and ascends ipsilaterally in your dorsal column. Right, so what is your main thing here? The main thing here is your dorsal root ganglion. So if you look at this picture here, right, you can see the same spinal cord again. Right, you have your ventral root, this red one, which is mainly for motor activity, right, with your anterior horn, and your dorsal root, which is with your dorsal horn, that's for sensory information. So the dorsal root ganglion they're talking about, that's right here, this thing. All right, so this is your first order neuron, dorsal root ganglion. First order neuron, things come here, right? Then it's going to come into here. We're going to see that next, right? Synapse 1 is going to be your nucleus gracilis or cuneatus, based off of, whether it's arms or legs. Gracilis legs, cuneatus arms. And it's going to go to the ipsilateral medulla, same side medulla. Then, second order neuron, you're going to have decussation in the medulla as things ascend contralaterally as the medial lemniscus. And I told you guys earlier, remember the medial lemniscus? We just saw it right here in the medial area. Those two big green beans. That's your medial lemniscus. And you can see how decussation is occurring now. And then it's going to go upwards, right? So things just came from here, right? So let's look at the connection, right? First things first, you had first order neuron, things came to your dorsal root ganglion. Then it entered here, came into your correct nucleus, depending on whether it was legs or arms, right? And then as you're ascending, eventually you get to the medulla, which is this right here. Information is going to come up using the same side gracilis, same side cuneatus, reaches the medulla, then it decussates, right, using the medial lemniscus. And as the medial lemniscus is going to go all the way to the top to your ventral posterior lateral nucleus of the thalamus, and then send it to the somatosensory cortex, and you're going to feel that. So let's take a look at that before we move on to spinothalamic tract. So down here, these two images are your two dorsal tracts, right, your dorsal columns. One of them is the more medial one, which is your gracilis for the legs, and this one is for the more lateral one, which is your cuneatus for your arms. Right, so you're seeing how I've labeled left for all of them, right? Because this is your left half, this is the left body. So basically what we're looking at in these dorsal columns are the right leg and right arm sensations, okay? So this one is showing you, any right leg proprioception, gets to the gracilis, ascends on the same side, gets to the gracilis, right? And now you're in the medulla. In the medulla, you're going to have the decussation. It's crossing over to your nucleus gracilis, going to your medial lemniscus, right? So nucleus gracilis ascended the same side. Keep that in mind. So any injury in your spinal column itself causes same side losses, right? But when it reaches the medulla, there's decussation to the medial lemniscus, and then it goes up contralaterally. So oftentimes you get questions. You get questions where injury occurs either at the spinal column or in the brain, and depending on where the injury occurred, loss is either ipsilateral or contralateral. For your dorsal column, right, things enter, ascend on the same side nucleus, but then decussation occurs in your medulla. So it's going to be different based off of where the injury was. If someone has damage to their spinal cord, they're going to have same side loss of proprioception, right? Because if I injure here, if I injure this, then I'm going to lose my right leg proprioception. If I injure this, I'm going to lose my right arm proprioception, same side. But if they have injury in the medulla or above it, anywhere above it, even up here, this is your thalamus. This thing is your thalamus. Anytime you see this shape, right, this is your thalamus. So in your thalamus, if you have injury because of some kind of stroke maybe or anything like that, you're going to have contralateral loss, right? Loss on the opposite side. Okay, so if you have injury on your left thalamus, for example, messing up this exact fiber that we're looking at, if you lose something in your left thalamus, you're going to lose your right dorsal column, which means you're going to lose proprioception of your right leg. Okay, so that's your dorsal column. That's it for that. Now, the next one, spinothalamic tract. The spinothalamic tract we basically mastered by now, right? Because we looked at it in syringomyelia. We understand how it decussates and how it comes up. So let's take a look. You have a lateral and an anterior spinothalamic tract. Generally speaking, we talk about them together. But do keep in mind, if you do get a very accurate, specific question, then it's about the lateral one, right? If they're mentioning pain and temperature. So how do these guys work? These guys use your A, delta, and C fibers. You do have to remember the fibers they use. They use the A and C fibers, bypass pseudounipolar cell bodies in the same dorsal root ganglion. The same thing we looked at, dorsal root ganglion. Again, it's sensory. It's going to go to the dorsal root, right? And then enters the spinal cord. It's going to synapse at the same side gray matter, right? Spinal cord, and that's your dorsal gray matter because it's sensory. And it decussates in the spinal cord. Decussates in the spinal cord before it starts ascending, right? So decussates in the spinal cord and ascends contralaterally after the anterior white commissure, right? And this anterior white commissure was what we were compressing in syringomyelia because there was a syrinx in your spinal cord and it just started pressing down on your anterior white commissure and things won't go up anymore correctly. And you end up messing up both anterior white commissures because anterior white commissure is where both sides are contralaterally decussating. So you mess up both sides spinothalamic tracts and you have bilateral loss of pain and temperature. Right, so now we could take a look at that. That's your spinothalamic tract right here. So you can see again, I've labeled your left, right? So this is your left body over here on this side. This is sensation coming from your right side, right? So maybe this person is touching a hot stove with their right arm, right? So the right arm sensing information goes right here. This is the first thing we saw. First order neuron was your dorsal root ganglion, right? So that's your dorsal root ganglion stuff right there. And then in the spinal cord, it decussates. It doesn't go up first. It decussates immediately in the spinal cord. That's very unique of the spinothalamic tract. The others decussate in the medulla or somewhere else, but your spinothalamic tract decussates in the spine. So pretty easy to remember that since it has spine in the name. Right, so it decussates in the spine and then it goes up contralaterally the whole time. And look, in the medulla, look at what it's using. It's using the spinal lemniscus. That's that third nucleus, right, lateral to the cuneatus thing, right? You have your gracilis, cuneatus, those guys were for your dorsal column. After that, you have your spinal lemniscus, which uses the trigeminal nerve. This is for your pain and temperature. Keeps going up all the way, and then reaches your VPL, nucleus, in your thalamus. Really straightforward. Nothing complicated about it. Syringomyelia is a compression right here at the spinal cord, messes up the decussation for both sides, so you get bilateral loss of your spinothalamic tract. And that's it. The last tract we have to talk about is our corticospinal tract, which I have right here. This is an image from Amboss. Alright, so this image is perfect for it. I couldn't find a similar image like this because the one I did have previously actually had an error in the image itself. So it wasn't drawn correctly. So your lateral corticospinal tract is your one descending tract that you really need to know. But there are more. Don't forget, there are many other tracts, but first aid only mentions these. I'm going to show you a couple other tracts. You don't need to know them that well, but it's good to have them at the back of your mind so that if you ever get a question about it, you know, something will ring a bell. Anyway, lateral corticospinal tract, what does this do? So this is for voluntary movement of your contralateral limb. Right? So corticospinal tract is, if your left corticospinal tract helps you move your right arm and leg, and vice versa. So in our diagram here, right, we're using the right corticospinal tract, which is going to help him move his left arm and left leg. So let's take a look at how that works. So information is descending. So it's going to start up here now. Starts at the upper motor neuron. Right? Remember, we're going to see questions about upper motor neuron and lower motor neuron lesions. And you really need to know what that's about. Anytime you have a question about upper or lower motor neuron lesions, it's basically an injury to your lateral corticospinal tract somewhere. Right? And where depends on what the lesion is. If it's an upper motor neuron lesion, it's up here somewhere. Right? Cell body in your primary motor cortex, which is in front of the central sulcus, is going to send information that descends ipsilaterally using your posterior limb of the internal capsule. Very important to remember that. The posterior limb of your internal capsule is a very high yield thing, gets tested very frequently. So that's your internal capsule right there. Right? Previously, we saw this diagram. We saw this cortical diagram and everything was labeled. Right? So your internal capsule is this white area in between. That's the internal capsule this is using. Right, uses the internal capsule, goes down, right, and then we're in the medulla now. This is your medulla with the pyramid. You see your squiggly olives, right? It's coming down. It's also called the pyramidal tract because it uses the pyramids, right? So you see how it's using the same side pyramid ipsilaterally. Right after the pyramid, there's something called the pyramidal decussation, which occurs in the medulla, but in the caudal medulla, in the lower part of the medulla. That's what I was showing you up here, right? This is the actual medulla. But below this level is your caudal medulla where the decussation is occurring. This is your pyramidal decussation. So the lesson to take away here is that your lateral corticospinal tract uses the same side internal capsule and the same side pyramid. Then it decussates and goes to your spinal cord. So you can see this is your spinal cord. You have the butterfly design now for the gray matter. And in your spinal cord, it will help you move your left arm and left leg. That's your pyramidal tract right there. That's it. Right, so you have your lower motor neuron in your spinal cord leaving. This is your lower motor neuron right there. Right, so upper motor neuron lesions and lower motor neuron lesions are going to have different kinds of effects in a person. The general theory is everything is up in an upper motor neuron lesion, where we say, oh, your big toe is going to be up, so you're going to have a positive Babinski sign. You're going to be flexing. Everything is going to be up. You're going to have hyperreactive, deep tendon reflexes. Whereas in lower motor neuron lesions, things are going to be down, right? So you're going to have flaccid paralysis and stuff like that. We're going to see that when we get there more accurately. But in the end, though, in the very end, everything goes to your neuromuscular junction, which actually helps you move. Okay, so those are your tracks. You need to spend time doing this. You're not going to memorize it all in one day either, nor will you be able to master it and talk about it without looking at it in front of you in one day. But you have to do it. You have to keep doing it 3 to 4 days in a row. Study the same exact thing back to back, because repetition is key. It's just like working out. If you do the same workout every week, right, eventually it becomes easier and you can do a harder version of it now. You won't even fatigue out. In fact, every time you revise it, if you did this today and you do it again tomorrow and again the day after, in 3 days, when you revise it every single day, it just becomes like common knowledge to you now, and it becomes so much easier, so much easier. The first time you look at it, it seems very intimidating, and you're like, how am I going to remember all these tracts? How am I going to remember where it's decussating and all the different parts of your brain? But it's not as bad as you might think the first time you try doing it. Right? I remember because I was doing it and it was really hard for me, and I was like, yo, this shit is really annoying. I don't want to sit here and memorize all these tracks and blah, blah, blah. But at the end of the day, that's what this is all about, right? Because you have to know the tracks. If you don't know the tracks, you can't work with the pathology, which is basically going to be lesions, right? So let me give you an example of lesions, right? We're going to see that on the next page. So this is the image that Dr. Aisha Masood here was asking about. I made a little mistake the last time I made this video talking about this image, but I've removed that video and I'm replacing it with this video now where I'm going to do it correctly. So first things first, when you get images like this, you need to be able to identify where you are immediately, right? So for example, if I show you this, you should know immediately this is your thalamus. This is how it looks. This is how the thalamus looks on a cross section, right? You can see your substantia nigra and all of that stuff, okay? This one here, this is obviously your medulla. You need to know immediately as soon as you see it, because you can see your pyramids, okay? You can see the squiggly olives, right? So that's how you get the medulla. Same thing everywhere. So if you look at this image, for example, here again, you can see your spinal cord. Different levels of your spinal cord have different design butterflies, which we'll talk about later on. But when you see the butterfly thing, the gray matter stuff in the middle, you know that you're at the spinal cord. And then you have your medulla with the pyramids and the squiggly olives, right? Then you have your pons, which looks really weird. It looks like there's some kind of mountain stuff happening here on a map, all right? And then the midbrain, which resembles your pons, but remember how the medulla had the pyramids in the anterior part, right? The midbrain has the similar kind of thing in the back. That's your colliculi, right? And depending on what level of the midbrain you're at, you're either going to see your inferior colliculus or your superior colliculus, right? And you can see in the midbrain, you're catching your inferior colliculus. When you get to the thalamus, you're catching the superior colliculus, which are both in the back. Alright, so really important to get that anatomy down. Once you can start identifying, different parts of your, different layers of your spinal cord and brain, and associate different landmarks to them, all pathology starts becoming a lot easier. So now you can see here in this image, there's two lesions, lesion A and lesion B, in your medulla. Right? And these lesions generally occur because some artery had a stroke to it. The artery stopped supplying blood to that region of your medulla. So what's going to happen now? Well, in lesion A, right, you're losing your pyramid, you're losing the medial lemniscus, right? You're losing this guy, and you have to remember who that guy was, right? What was this nucleus? This nucleus all the way over here, the first one. We saw it earlier. That's your hypoglossal. We saw it right here, the red one. Right, this is your medulla. You can see the you can see the layer that they're showing you here. Right, that's the cross section of your medulla. In your medulla, you can see your hypoglossal nerve has your nucleus over there and it exits over here. So in our lesion A, we're actually messing up this area, right? We're messing up this entire thing. In lesion B, later on, I'm going to show you that one too. You're going to be messing up this entire thing, which is your vagus nerve. Right, and we talked about our vagal nuclei, the sensory solitarius for taste, the motor ambiguous for swallowing, and your dorsal motor for parasympathetic innervation of everything else your vagus nerve covers up to your upper GI. So heart, lungs, and upper GI. Right, so that's what you want to keep all of that in mind, because that's where you're going to see every time you see a lesion. So now in lesion A, what are you going to have? you're losing your left medial lemniscus, which is for your dorsal column, and your left pyramid for your corticospinal tract. Right? The pyramid was what your corticospinal tract used. Your dorsal column used the medial lemniscus, and these are all the things it used for decussation. So this is due to a lesion of your anterior spinal artery, which is actually right in the middle here. Alright, so you lose your anterior spinal artery, you lose this guy. You could lose it bilaterally, or you could just lose one side. So what are you going to lose? You're going to lose your left dorsal column and corticospinal tract. Right? You're going to lose both your left dorsal column and your left corticospinal tract. Remember, this is the patient's left. Right? This is the patient's left side. Lesion is happening on the left side of the patient's dorsal column. Left side of patient's pyramid and medial lemniscus. So now, when you lose those guys, you're going to have loss of right limb proprioception, because remember, decussation is going to occur. So you're going to lose your right limb proprioception, you're going to lose right limb motor activity, and you're going to lose the same side hypoglossal nerve. Hypoglossal nerve isn't going to decussate, right? It's a cranial nerve. It just comes out and goes to the tongue. It doesn't even go below your spinal cord, right? It's just coming from the brain straight to the tongue. That's it. It's for the motor activity of the tongue. And you have to remember the mnemonic for the hypoglossal nerve lesion. It was lick your own wounds, right? So that means that if you lose your left hypoglossal nerve, the tongue deviates to the left. Okay, so you have to remember that. So in these patients, you're going to see that this is called medial medullary syndrome. And you can see where the name comes from now, right? It's your medial medulla. This is the medial medulla. You're messing up your pyramid, you're messing up your medial lemniscus, you're messing up the hypoglossal nerve. When those things are gone in the same patient, you know they have medial medullary syndrome, and you can expect them to not have proprioception of their right limb, not be able to move their right limb, and not be able to move their tongue correctly, right? But what else you always want to remember, and we always did this every time we did a question in the past, I always tell you guys, think of things that are not in the question, right? So things like being able to swallow, being able to feel pain and temperature, those should not be in the question because it's irrelevant to this medial area. Okay. Now we could take a look at lesion B. So lesion B is messing up these nuclei, which are your nuclei for the vagus nerve, right? This is your vagus nerve exiting right here. See, cranial nerve 10. So if you're messing up all of that, and then look at what else you're messing up. You're messing up your spinal nucleus. Remember the spinal nucleus, the guy that was after the gracilis, cuneatus, and spinal nucleus. Remember who used the spinal nucleus? Right, so spinal nucleus was being used right here by your spinothalamic tract, right? This third guy. So you're going to mess up your spinal nucleus when you have a lesion like lesion B. So you messed up your spinal nucleus, you messed up your vagus nerve, and now you should know what you're going to expect in your patient, right? So you're messing up your left spinal lemniscus for the spinothalamic and lateral corticospinal tract. Okay, so lesions of your posterior inferior cerebellar artery are what are going to be responsible for this. Colloquially just called a pica injury, right? So posterior inferior cerebellar artery lesion, you're going to lose this area, you're going to lose your vagus nerve, you're going to lose your spinothalamic tract. So you're going to basically have loss of right limb, pain and temperature. You're going to lose some right motor activity, and you're going to lose your vagal nuclei, which means you're going to be unable to taste your food, you're going to have difficulty swallowing your food, and you're going to have weird parasympathetic losses in your lung, heart, and upper GI. Right? We're going to see that when we get to that stuff in the pathology. But really important to be able to come back here and make that connection, right? You don't want to sit there and memorize each one of these pathology and what they're going to lose by any kind of weird means. You want to actually know what was injured and what was lost, because that's what your question is going to be on. Right? So you might get a question on a patient with medial medullary syndrome, a patient that came in saying, you know, he has loss of right motor activity, his tongue is deviating to the left. You know immediately right motor activity is lost. He has an injury on the left side. His tongue is deviating to the left also. He's lost his left medial lemniscus. He's lost his left pyramid. And the answer choice you need to pick might actually be, oh, injury to the left pyramid. Right? And you have to remember that the pyramid was related to this, or you won't make any sense out of it. In fact, it could be even an upper level question where a patient might have had a stroke in their brain and lost their internal capsule. Right? That also happens. Very common thing. So if you lose your internal capsule, again, you're going to lose your motor activity. Right? But then your medulla is going to be fine, your spinal column is going to be fine, and they'll tell you all of that in this question exactly right here, actually. So let's take a look at this. 76-year-old woman, this is from AMBA, 76-year-old woman with hypertension and coronary artery disease is brought to the emergency department after the sudden onset of right-sided weakness. Her pulse is 83 per minute and blood pressure is 156/90. Neurological exam shows right-sided facial drooping and complete paralysis of the right upper and lower extremities. Tongue position is normal and she is able to swallow liquids without difficulty. Knee and ankle deep tendon reflexes are exaggerated on the right. Sensation to vibration, position, and light touch is normal bilaterally. She is oriented to person, place, and time and is able to speak normally. Occlusion of which of the following vessels is most likely cause of this patient's current symptoms? Now, each sentence in this patient's neurological examination gave you very valuable information. So let's see if you were able to catch all of that. First thing they told you, neurological exam, right-sided facial drooping and complete paralysis of the right upper and lower extremities. So when you have paralysis, you lost motor activity, that means injury is to the corticospinal tract. But the right-sided facial drooping is a sign of injury in the cortex. But maybe you didn't catch that, right? Let's say for some reason you didn't catch that there. Then they go on to tell you tongue position is normal, which means the hypoglossal nerve is not injured, so the lesion isn't over here, right? The lesion is not over here in the medulla, okay? She is able to swallow liquids without difficulty. So swallowing is okay. That means the lesion is not over here where the vagus nerve is coming out. So both of those are fine. That means the medulla is fine. So we just canceled out two arteries, right? We canceled out the anterior spinal artery. We canceled out the posterior inferior cerebellar artery. They go on to tell you knee and ankle deep tendon reflexes are exaggerated on the right. Now you should, something in your brain should make a connection. You saw right-sided facial drooping and exaggerated deep tendon reflexes on the right side. Those things combine to tell you there's an upper motor neuron injury. Remember I told you with upper motor neuron injuries, everything is up. This patient's deep tendon reflexes are up, right? They're exaggerated. And upper motor neuron injury does cause facial drooping, and we're seeing that. So now all of that is hinting us that the injury is somewhere here, somewhere in this, not at these levels at all. They further confirm that these levels are okay by telling you that sensation to your spinothalamic tract is normal bilaterally, which is very important to say bilaterally because most times you lose your spinothalamic tract, it is bilaterally, just like we see in syringomyelia, because decussation occurs immediately at the anterior white commissure in your spinal cord. She is oriented to person, place, and time, which means she doesn't have dementia. She could speak normally, so her Wernicke is working, her Broca is working, all of that, because she's understanding what's being asked, right? Person, place, and time. So none of that is lesioned. Occlusion of which of the following vessels is most likely cause of this patient's current symptoms? Now, Broca and Wernicke working is also related to arteries, right? There are arteries associated with both of those. You're going to see later on your, let me see if I can find it for you guys, actually, real quick. Broca, yeah, see? So right here we're going to see your Broca, Broca is superior division of MCA, Wernicke is inferior division of MCA, your middle cerebral artery. So if that was an answer choice, we would remove that answer choice too because this patient is understanding stuff and speaking correctly. So now you're probably down to just two answer choices, and you have to remember that the only way this old woman with hypertension could have lost motor activity in the brain is due to a lenticular striate artery stroke, which is very common, colloquially just called a lacunar stroke. So let's read the explanation now. This patient has features of a pure motor stroke without any sensory deficits or cortical signs. Aphasia, agnosia, apraxia, she doesn't have any of that. The lesion is most likely located at the posterior limb of the internal capsule. That should ring a bell. We just learned about this thing right here. That's the posterior limb of the internal capsule as things come down the pyramidal tract. A pure motor stroke is caused by infarction in the posterior limb of the internal capsule, which contains the corticospinal and corticobulbar fibers that innervate the motor nuclei on the contralateral side. Therefore, a lesion at this site can cause contralateral hemiplegia as well as weakness in the lower half of the face because of the region of the facial nerve nucleus that supplies the lower half of the face only receiving unilateral corticobulbar innervation. And you're going to learn that later on, but basically the lower face is only innervated by one thing, right, unilateral, whereas the upper face, your forehead, has innervation from this side and that side. So your your forehead is often spared in these upper motor neuron lesions. Lower motor neuron lesions will mess up both things though, because by that point you have a decussation from both sides. And we're going to see that later on, right? So if you don't know what I'm talking about, you're going to learn that later on, but keep that in mind, right? They tell you right here, facial nerve nucleus that supplies the lower half of the face only receives unilateral innervation, only from one side, and then it goes to the lower face. That's the facial nucleus, not this thing. Facial nerve nucleus only supplies only gets one side supplied to your lower half, but gets dual supply for your forehead. So your right forehead also gets supply from the left side and the right side, and that saves your forehead oftentimes, and we're going to see that when we get there. Other cranial nerve nuclei, as well as the region of the facial nerve nucleus that innervates the forehead, receives bilateral corticobulbar innervation and are therefore spared. The most common cause of a stroke in this region is a lacunar stroke of the contralateral lenticulostriate artery, which is a branch of the MCA, right? And this occurs in hypertension, which she has, 156/90. Okay, so that's basically your major tracts. Here I'm showing you 3 more tracts that are very low yield. You don't need to memorize the tracts per se, but you should know they exist. That's all I'm trying to get you guys to do here. Just know they exist. So let's look at this image first. Let me make it a little bigger. So on this image you're seeing 2 tracts. The red one is your Rubrospinal tract. It comes from the notorious red nucleus. Right, your red nucleus is very high yield. In fact, probably the most high yield of these 3 things is the red nucleus. It shows up pretty commonly. That red nucleus is for the Rubrospinal tract. It's coming from the thalamus. Right, the ventral tegmental decussation occurs in the thalamus. After that, it decussates on the contralateral side the whole time. Right, so decussation occurs really early in the thalamus. It decussates in the thalamus and descends contralaterally through the medial lemniscus and ends at the anterior gray column for flexor muscles. Remember, anterior things are for motion, right? So you can see the red thing is coming down, uses the medial lemniscus, right? And then goes all the way to here, which is the anterior part of this butterfly design, for flexor muscles. Okay, so you're often going to see that when you lose your red nucleus, the patient is not able to flex. And that's a very important fact to remember. In fact, I'm going to show you guys why right now, because there was a very good UWorld question and diagram showing you this. So you see how you have the cerebral cortex, then it goes to the red nucleus, and if you have a lesion after the red nucleus, right, then you lose all your flexors, and you see how the dead person is not flexing. That's a giveaway. This is called the decerebrate posture. You lost your red nucleus, you lost your flexing, so this dead person, the extensors are winning, so he's laying flat and extending. In another injury, you could actually lose something before the red nucleus, right? So you lose it right here at the cerebral cortex from your motor area of the cortex, right, before it reaches the red nucleus. You lose that, then the red nucleus is still working, and you see how this patient is flexing. Right, the flexing. So these are real things that occur when a patient is found dead, whether they're dead in the flexor position or the extensor position. It kind of gives away where the injury occurred. Right, and you can see the other nucleus is your vestibular nucleus. So I'm showing you both of those right now, right, because you need to know them for the pathology. So right here, right now I just showed you the red nucleus one, which is in red here, right, and that was for your flexors. The vestibular one is this one over here. It has 2 branches to it. Don't worry too much about that. But what do you need to know about the vestibulospinal tract? So the vestibulospinal tract, which is here on the left, uses the vestibular nucleus in the pons. Remember, you have to remember where the nuclei are located, right? The first 4 are above the pons. The middle 4 are in the pons, and the last 4 are in the medulla. So the middle 4 has number 8 in it, and 8 is in the pons, right? So the vestibular nucleus in the pons, axons descend uncrossed using the olives and the medial longitudinal fasciculus, your MLF, which is actually really important for vision, and synapses with the anterior gray column for extensor muscles, right? This tract is actually really significant for for many things, but mainly just the thing I just showed you guys, where the decerebrate and decorticate position, right? So decerebrate and decorticate position, you have to memorize those positions because you can get a question where they might just tell you, oh, we found a patient, he was dead, he was laying like this, where was the lesion? right? So if he's laying while he's flexing, his red nucleus is working, so this is a decorticate position. But if his red nucleus is not working, he's laying extended, it's a red nucleus lesion right here, that's your decerebrate position. Okay, you lost your cerebral input, decerebrate. Whereas here, your cerebral input is still kind of working because the red nucleus can work by itself using the Rubrospinal tract that we're just looking at. The other guy is your vestibular spinal tract, which we just saw right now. It never crosses, it goes down uncrossed, that's pretty unique, and it goes to extensors. Okay. The only other thing here is this blue one now. This blue tract is called your Tectospinal tract. I've seen questions on it, so in all honesty, I couldn't find a picture that was nice and only showed the red nucleus, so I have to talk about this too because it's here, but I have seen questions on it, mainly by Kaplan, never on UWorld. Your Tectospinal tract is in blue here. It connects to the superior colliculus, which remember you have to know these landmarks. Superior colliculus in the thalamus, inferior colliculus in the midbrain, right? Then you have your pons, which looks like this every single time, medulla with the olives and pyramid, and then the butterfly areas are your spinal cord. So it uses the superior colliculus, which, remember, superior colliculus, your eyes are above your ears, right? Superior colliculus is for looking, inferior colliculus is for hearing. And you can see the inferior colliculus is kind of slightly being involved over here where you're using your vestibular spinal nuclei. But either way, this thing, tectospinal tract, it connects to the superior colliculus, which is related to vision. This tract is key for reflex movement of the head and neck in response to any visual stimuli. So if I suddenly throw something at you like a ball or my phone or something, you should be able to catch it because your tectospinal tract is working. Okay, and that's generally all you need to know, basically, as far as tracts go. No mistakes were made this time. Everything's good. Everything's very accurate. Did a good job showing you the tracts, showing you how they work, what they're relevant for, main pathologies, and that's it. That's really all there is. This last page is very irrelevant. It's a very easy page, not much for me to do here. Remember the cheat sheet we've been talking about since like way in the beginning? We added a lot of stuff to the cheat sheet. Page 1 was mainly just epidemiology and biostats equations and graphs. Page 2, I've been developing it. It's almost done. Page 2, I put this guy on it too. So I can actually show you guys right now. Let me see where I put it. I'm going to post a picture of page 2 soon enough as well. It's almost done. But basically, just to remind you guys again, so let me make sure I can see what you guys can see. Okay, so we did page 1, right? This was page 1 with all your epidemiology and biostat stuff. This is the stuff you would memorize and revise every single day and keep rewriting it until you have muscle memory of rewriting it, so that when you get your scrap paper, you can do that. Page 2, the back of it now has all of this. So first things first, I put the Men's syndrome for people who can't memorize it, right? You keep rewriting it. If you end up memorizing any of this stuff while making memory of it, you can stop writing it, right? That's another thing. You don't have to remember it for your scrap paper anymore. Anyway, I put the Men's syndromes on one side. I put the mud pile stuff on the other side, right? And the middle is all your acid-base stuff, right? So memorizing the acid-base graph and the alkalosis and acidosis, those equations for alkalosis, acidosis. And then I had the clinical reflex guide right here, right? And your cranial nerves, memorizing the groups of 4s for your cranial nerves. So you can go ahead and do the same thing too. Just keep it all there. I also wrote down the sleep physiology stuff. The beta alpha theta, bats drink blood at night, right? So it's nice because when you're doing something like this, you're writing, you're using different memory, you're using muscular reflex to actually memorize, muscle memory I mean, not reflex. So when you do all of this, when you memorize everything in this manner and you prepare a scrap sheet for your scrap paper, you actually utilize your scrap paper very usefully, right? So when you sit down for your test, you get your 2 pieces of scrap paper back to back. One of them should be full of stuff you memorize before you start your test. And that's what you're preparing here, right? You're training for what you're going to write on your scrap paper. So I'm gonna upload those images soon enough on the YouTube page and put it on my Facebook page as well. You can find them in either place. But basically, I put the clinical reflexes there, but instead of writing it like this, I only wrote the main guy. So I put, up here for the biceps, I put C5. Here I wrote C7. Here L4, and at the bottom S1, because these do get tested. And the best part about it is it's usually a giveaway question. So if you get a question on it, it's just memory. Do you remember it? Do you not remember it? If you do remember it, you're done and you can finish it. If you don't remember it, then hopefully you can guess well. As far as primitive reflexes go, just remember that all of these reflexes are normal in an infant, a little baby like this. But as soon as you do any of these in an adult, imagine a suckling reflex or rooting reflex in an adult. Like, that's obviously going to look really weird, right? Same thing for the plantar reflex. It's called the Babinski sign when an adult does it, right? It signifies upper motor neuron lesion, which I just told you guys, in upper motor neuron lesions, everything goes up. That's bad, right? So when you run this pen or pencil or anything across an adult's foot like that, if their toe goes up and everything else fans out, that's a sign of upper motor neuron lesion. They have some kind of lesion in their brain, which is kind of messing up the correct sensations, right? Otherwise, in any adult, and you could try this, in any adult that does not have an upper motor neuron lesion, when you run a pencil or pen across, or any stick across the sole of their foot, all the toes should come down. They should flex. Right? Flexion should be working because the red nucleus is working, everything in your cerebral cortex is working. That's what this should do. If you do this to someone and their toe goes up, you might want to tell them to go, get that checked out. And the last thing here is your landmark dermatomes. These we spoke about a little bit when we were in musculoskeletal. I love all the little things they have here for you to memorize it. Right, everything here they made up is perfect for memorizing. We talked previously about your thumb at being a C6 because when you make a thumbs up, it is 6. The only thing they don't talk about here, so spend time memorizing this, look at it, do a good job with it. Nothing for me to talk about with it. But what I want to add, what they didn't put here, is the sole of your feet. Okay, so they stopped at L4, but mainly, if you look at the feet, right, this is the front and the back. The big toe is L4, right? All of this is L4. You see how it's kind of wrapping around the body in a weird way because your limbs do rotate, right? Our hands flex this way, but our legs flex the other way. So things do rotate, but because of that rotation, L4 is for your big toe, but all the others are L5. Okay, so L4 is your big toe. The rest of them are all L5. The top of your feet are L5. And the bottom of your feet are also L5. Okay, so you can get basic bullshit ass questions on that stuff. That's the only thing they haven't mentioned here, L5. Other than that, you're pretty much done. This I'm gonna actually end up moving to where they talk about urinary incontinence, because urinary incontinence is a very high yield topic. And first aid or even Kaplan don't really talk about the micturition reflex a lot. Micturition is urinating. The micturition reflex is regulated by the following centers. The sacral micturition center, which is at S2, S4, is for bladder contraction. Your bladder has to contract to get the pee out. Parasympathetic fibers travel from S2 to S4, ventral white matter, within the pelvic nerves and stimulate the cholinergic receptors in the bladder wall. All right, parasympathetic is for rest and digest. Peeing is part of digest. Pontine micturition center is located in the pontine reticular formation. This guy is also really important because it coordinates the relaxation of your external urethral sphincter. If you don't open that sphincter, you will not be peeing. Okay? The cerebral cortex stops it all, and that's it. Okay, so cerebral cortex would be more for sympathetic stuff. When you're in your fight or flight mode, you should not be peeing. Alright, so spend some time within the next 2 days, if this is what you're studying right now, spend some time within the next 2 days revising this again. Go look at the tracks one more time. Understand how the lesions look like, what the lesions are going to be about, what you're going to lose with each lesion, which I show here, A and B, your two main lesions, and how your tracts kind of decussate, what the whole concept is, why your brain looks like the way it does. Memorize where the various parts of the tracts are on your spinal cord. Understand where the different nuclei are, right? Your cranial nerve, where they exit. Not so much the skull. I wouldn't worry about this too much. When I first talked about this, I already spoke about it. It was really easy to memorize. Standing room only is one really significant thing, but the others are all really easy to memorize too. It's not that hard. It just takes time. You're not going to memorize it the first time you look at it. This is also pretty easy to work with. We talked about this in its video, discussed all the fours and methods of knowing where all of these are. So if I ever give you a blank image like this one, right, or this one, this is the dorsal view, right, with the cerebellum being removed. It's rarely used. This is the one you'll really get to see all your cranial nerves, right? Your ventral view from the front, because all the cranial nerves generally come out in the front. There's only one that comes out from the back, and that's your the trochlear nerve, number 4, comes out from the back. But generally speaking, if I ever give you an image like this with nothing labeled, you should be able to label all the cranial nerves, right? And that's what you want to practice. If you can find blank images, and you can find blank images, then, take those blank images and try labeling everything on your own without cheating. And that's it. By the end of this section, before starting pathology, you should be able to talk about these tracts without looking at the book. That's what you want to get at. So talk about the tracts, talk about the entire pathway they take, talk about the main players, right? So you have, for example, here the internal capsule in your pyramid. For your dorsal columns, you had your gracilis and cuneatus and the medial lemniscus. Right, and for your spinothalamic tract, you had immediate decussation and you used the spinal lemniscus. You should be able to talk about all of that without the book in front of you, and discuss these pathologies and what they do without the book in front of you before you actually dive into neuropathology. Right, so that's what the next video is going to be about. I'll be back in like 10 minutes. I'm just going to get something to eat, and I'm going to continue this right now. Okay, but for your own study purposes, make sure you actually master the physiology and anatomy before you come here, because then when you start reading all the different pathologies here, everything is going to be already making sense to you. All right, so thanks a lot for joining, guys, and then I'll see you again in a bit.